Welcome back to the Kolender Medical Radio Show. I'm your host, Anne-Marie Cronin, here talking with Dr. Brian Kolender, board certified in internal medicine and specialist in artery disease, with offices in Bingham Farms and downtown Detroit. Dr. Kolender is here with us discussing his concierge practice and how to avoid heart attack and stroke, and how to begin the reversal of artery disease. Now, Dr. Kolender, in the last segment you were talking about why a stress test isn't the answer to everything and the difference between plaque and blood clots. Can you pick up where you left off?
Yes, Anne-Marie, thanks. So this is very important, everybody, and I understand why this might be difficult to hear and understand, because it totally goes against everything you've learned and heard from anybody in medicine up to this point. So it's hard to grasp, and it's hard for other doctors to understand that heart attacks and strokes are not caused by blockages. They are caused by blood clots, and the blood clots occur because a mild, and I'll say that's a misnomer, a mild plaque ruptured. Your body wants to heal that rupture, and a blood clot forms to heal it. That blood clot ends up blocking the rest of your artery quickly and causing you to die from a heart attack or have a disability from a stroke. So doing blood flow tests like a stress test, a Doppler, or a CT angiogram, even a heart catheterization, which is considered the gold standard, is going to miss subclinical disease. And this is important. Most of us have subclinical disease, and it's not being recognized. The current system is based on treating end-stage disease. So when you go get a stent or a bypass, that's called end-stage disease.
Well, if you're going to get a stent, you're already in trouble. You're in major trouble by that point, right?
Well, you're in less trouble, actually, than some...
Then if you die, I got it.
Right. So we already said that blockages don't cause heart attacks or strokes. Mm-hmm. Most people, the 80% have subclinical disease. They have no idea what's going on because they're not getting the right tests. They're not being evaluated in a proper way.
Okay, so let's run back again over this testing hierarchy. So you get the stress test, and then what is the CT angiogram, and who gets that? Who gets sent for that? And the next, what was the next test up you were talking about?
Well,
those are invasive tests, aren't they?
They're very invasive, and even if they're not invasive, they involve a lot of dye that bothers your kidneys. Mm-hmm. They involve a lot of radiation, which none of us need, and frankly, again, they're not identifying the cause of death and disability because they don't catch subclinical disease. How many people walk away from getting a carotid Doppler or a CT angiogram and are told, it's okay, you only have mild disease? It's because it's not actionable to the cardiologist right now until you get to 70%. When you wait that long, first of all, you gotta live long enough to get to 70%. You might rupture and die before then. And we gotta prevent this. No one's looking at prevention. So to understand prevention, you need to understand that we're looking at for inflammation. Inflammation is this very vague term that we throw around, but we all experience inflammation in different ways all the time. Eczema is inflammation. Eczema is a mild, dry rash on your skin. People with irritable bowel syndrome, that's gut inflammation. People with back pain, that's inflammation of your ligaments and muscles around your back. Inflammation occurs in so many ways. If you have kidney stones, that generates inflammation of your ureter and kidney. All of these sources of inflammation have an impact on your artery. So what we want to do is identify the impact of all of this inflammation on your artery. And there's only a couple ways to look at that. And one of them is to do what's called a CT calcium score. And that's a 10-minute CAT scan of your heart. There's no dye. It's low-dose radiation. And what we're learning from that point is, are you making hard plaque, calcified plaque? Why is calcified plaque important is your next question. That's how we heal. And let's say, you cut your finger and it heals with a scar tissue. And that scar tissue is hard. It's not gonna rupture. Well, when you heal an area inside your artery, we want it to heal with scar tissue. And a lot of times when your arteries in your heart heal, they heal with calcium plaque. It's not a bad thing because that calcium is not going to rupture and cause you to die. So a CAT scan of the heart identifies, do you make plaque or do you not?
What about where it is and why? I mean, doesn't it get, you make more and more and more plaque? I mean, if you're already, and I know it goes by numbers, if you're 0 to 100, you're in one category, and if you're 100 to 300, you're another one, and if you're over 1,000, you're in big trouble. But isn't it also where that plaque is, and what the concentration of plaque is, and why are some people up there at 1,000 and other people are down there at 100?
Okay. Those are good questions and might be beyond today's talk.
Okay.
But from a prevention point of view, all I want to know is, do you make plaque or you do not make plaque? Because there are people that don't make plaque, and there are people that just don't develop plaque at all.
Why is that?
We don't know. Maybe they have some genetic SNP that we don't know about. And again, we'll talk what that term means one day. But they may be healthy. There are people that are healthy out there. And the answer is, the reason why we need to know where you are is, I don't want to overtreat you. I don't want to give someone without plaque, who have no artery inflammation, a cholesterol drug if they have high cholesterol. Why should I give you a drug which I would consider a poison? It's a chemical. I don't want to give you a chemical that you don't need. So I need to identify, do you have disease? So the first step is the CAT scan to tell me, do you make calcified plaque? And a 0 calcium score is not reassuring. Even though it's half of the picture, it's not reassuring. 20% of people who have severe plaque and who've had heart attacks have a 0 calcium score because they make soft plaque.
There's a difference in the plaque on the CT scan?
There's a difference in plaque between all of us. So there's different kinds of plaque. There's different way that plaque heals, and how your body heals plaque and the way you make it will indicate where your course in the disease process goes. So having a high calcium score can be good and bad. It could be, I made disease, but I heal it quickly and it's not going to rupture, versus I have soft plaque that's going to rupture. Soft plaque ruptures, hard plaque doesn't. So people that are more predisposed to hard plaque are the ones that are going to not die but move on to getting a stent. They'll have a quote unquote blockage. It's the people that have soft plaque. So now the great question that we need to ask is, how do we identify soft plaque? And there's a simple test that we do in our office that is not being done anywhere else. And it's an ultrasound. It's non-invasive. It takes 10 to 15 minutes. And we can actually look at your artery and see what's going on with your inflammation. So we're going to talk a little more about this in detail in the next segment, but we keep coming back to the word inflammation. Your artery gets inflamed, and I like to think of it almost as like a pimple. You get a little pimple and it pops. That's what's happening in your artery, except that pimple popping isn't a little bit of pus. It's like pus with cholesterol goop in it, and that's what's going on.
All right, well, we'll need to come back and talk more about these tests, but we're going to have to take a quick break. In the meantime, you're listening to the Kolender Medical Radio Show. You can reach Dr. Brian Kolender by calling 248-737-0091. Again, that number is 248-737-0091. You're listening to the Kolender Medical Radio Show on News Talk 760.